these wonderful rounds. We have learned a lot over these rounds in last 1 year. And, one of the reason we got interested in developing a GN problem is a GN program is because you brought it to our forefront that how little we know about the GN and the advances which have happened in GN. So I'm very pleased to share with you that our program has hired two new staff members. They will be starting January 1st, and they are currently doing training in GN. So our number one hire is Dr. Parnia Riaz. So she is currently doing a GN fellowship at UHN with Dr. Michelle Latinovich and Dr. Heather Reach, which, Dr. Latinovich is the GN lead for ORN. So welcome, Parnia. If you want to say something about yourself, please go ahead, unmute yourself, and then we'll move on to our second hire.
Thank you, Dr. Wadera. Very, very pleased to meet all of you. My name is Parnia, as Dr. Wadera already very kindly mentioned. I'm very much looking forward to meeting everyone this coming year. I'll be finishing my fellowship officially in June. And so, expect that as, the year grows, then the knowledge will also build in that time. I'm looking forward to working with everyone.
Thank you. And the second physician who we have hired into our group is Dr. Sanchit Madan. You may recognize him because he did an elective with us, and he came highly recommended by everyone who has been in touch with him. He's currently doing a GN training at McMaster, but he's also doing a GlomCon fellowship. So we look forward and we welcome Dr. Sanchit Madan. Sanchit, do you want to say something about yourself?
Yeah, for sure. Thank you so much, Dr. Wadera and Dr. Reen, for inviting me to this. And I'm looking forward to the opportunity to meet all of you. And very excited to be here and learn new things about this exciting area. So thank you. Thank you once again. And very nice to meet all of you.
Thank you. Thank you, Dr. Reen, for giving us the opportunity to introduce our new members in our division.
Okay, thank you. Thank you, everybody. Welcome, Dr. Riaz and Dr. Madan. Hope to work with you, and I hope you teach me something and bring you something to our field of glomerulonephritis, which happens to be my favorite subject in nephrology. Anyway, let's start the first patient. Could you guys give me the slide, please? Okay, before we go, we have changed the demographic of the patient so that we can respect the identity of the patient, so confidentiality is maintained. This case actually this was our first GN case about a year and a half ago. And I'll give a short summary to remind everybody. At that time, we were thinking a little bit differently. We should do this and that. But I think that time has come that we should do appropriate test in this condition. And I think Dr. Whittier and I know Dr. Radvi's on, and they had a similar case about a month ago. And the gentleman, the physician who actually described this lesion first, the pattern of injury, was in the audience. So I learned a lot at that time. So I thought I will share with you, and hopefully we'll treat these patients differently. So this was a 35-year-old gentleman of Guyanese Caribbean ancestry. He had a history of deep venous thrombosis, unprovoked pulmonary embolus a couple of times, and was started on Coumadin, and he was actually reviewed by hematology, and they did not feel that he had endocardial lipid antibody syndrome or any other hypercoagulable state. He was maintained on Xarelto. Then he somehow he stopped medication and he had another bout of pulmonary embolus, and then he was converted to Coumadin. And he came to my contact because he presented with the proteinuria of about 5 gram and creatinine of around 250 micromole, which turns out to be near about 2.5 milligram in American units. So his family history was that one of his cousin had probably cutaneous lupus. We weren't sure and he wasn't sure, but there was no history of any chronic kidney disease. There was no use of any indigenous medication or over-the-counter drugs, no history of any sickle cell disease trait or thalassemia. He was slightly obese with BM of around 28, blood pressure of 120 over 80, and every other physical examination was normal. Could you give me move forward a little bit, please? Next slide. So his hepatitis B screen HIV was all negative. Complement levels were normal. He had no paraproteinemias, but his free kappa chain, lambda chains were slightly up, and lambda ratio was slightly up. He had beta-2 glycoprotein higher in 150, and his IgG glycoprotein was 143, and kidney size was normal. I think the EULAR criteria for anticardiolipin antibody published about 2 days ago, which I haven't reviewed completely, but I think this guy actually qualifies by every criteria to be anticardiolipin antibody syndrome. So he had bone marrow because he had thrombocytopenia and slight leukopenia, and bone marrow was normal. That was done before he even saw me. Actually, when he was seeing me, he had during that time at the suggestion of his hematologist. So I discussed with him, can we stop his Xarelto? He was started on Coumadin later. He said, oh yeah, we can stop it. And so he underwent kidney biopsy. Can you show me next slide?
Sorry,
Dr. Reen, your screen sharing is off.
Yeah, just one moment. We're fixing it. 1 second. Sorry, guys, just give us 1 second. The screen just stopped sharing. 1 moment.
Okay. So I'm not going to share the kidney biopsy. Just go back. Okay. So kidney biopsy was performed, and he actually had membranous-like picture with very little IgG, and there was a C3. And our pathologist was quite appropriate in requesting pronase digestion, and it turned out to be had a kappa restriction there. So he's a classical case of membranous-like glomerulopathy with masked IG kappa restriction. And the reason I wanted to present at that time, there was a lot of discussion in our group that bone marrow was indicated and sort of it was a clonal disease. I even felt at that time it was actually autoimmune disease. And this guy actually had anti-DNA, anticardiolipin, very suggestive of anticardiolipin antibody syndrome. So he had this kind of picture, and as everybody knows, those patients are associated with this. And so I go next slide. Next slide. So this is the indication pronase digestion. It has two mechanisms, two ways it is useful. One is salvage. When you have frozen tissue not available, or there are very few glomeruli, you can do and find out any IgG deposition or clonal deposition. If you're thinking of light chain proximal to tubulopathy, or if you have some patient with abnormal free light chain, and You are right, it's a classic site. And so this actually, you can unmask those things. And membranous proliferative glomerulonephritis, where you're suspecting cryoglobulinemia and you're trying to look at unmask any glomerular disease. And you have membranous where weak IgG or patient looks like C3 glomerulonephritis are atypical, and you can actually do the pronase digestion, which is our case. So so we were able to diagnose that by unmasking by peripheral pronase digestion. So there are your indication. I think Suman Bear asked me what are the indications. Here are the indications of pronase digestion. Next slide. One of the at that time when we presented this case, Dr. Larson actually wrote the role of serum amyloid protein and staining in that, and his suggestion was that this is very diagnostic of this disease. And as you see here, we have highlighted that 32 patients out of 32 had presence of CAP. So this has become a very diagnostic tool. If this stain is positive and you have pronase digestion, Ig kappa restriction, it's a suggestive of very suggestive of monoclonal membranous like glomerulonephropathy with mass IgG kappa restriction. Next slide. So we did SAP on this. I sent me and Dr. Shubha Buller sent this slide to Arcana. Dr. Chris Larson was very kind enough to do that, and he was positive. So the lesson learned from this thing is, and when we are discussing that case, Dr. Whittier or Dr. Radby or even Dr. Rubin were there, they can chime in that he was of the opinion this is very diagnostic. It's an autoimmune disease, although slow progressive, but can lead to ESRD. And I'm worried about my patient that he had a stage 4 chronic kidney disease when he presented to me. And more important, it can recur in transplant patients. So this disease should be treated. I don't think we should sit down and wait and watch for it to do. We should. Although treatment is not evidence-based, but immunosuppression has been used. I used prednisone and Cellcept in this patient. There was partial response, but he didn't want to take pills. We have converted into rituximab. He received his 2 doses of rituximab about a month ago, and we are going to follow up how he's doing. So my message to you about this disease is that serum amyloid protein is very specific for this disease. It's an autoimmune disease, so we shouldn't be wasting money and time and energy doing bone marrows and clonal works and this and that. Just go straight treat as autoimmune disease. It can end up in end-stage renal disease, especially if they already have impaired kidney function. And more importantly, it can also recur in transplantation. So we should do level best to treat this patient so that we can prevent the kidney disease. And moreover, it's found in young people, found in mostly in female, as Dr. Radby suggested. But it fits classical in the era of lupus nephritis and lupus disease and young people disease, mostly female. So I thought that I will share, and the question somebody asked me was, what are the indications of pronase digestion? I hope I have answered that. Any comments, Dr. Whittier? You have reviewed this thing at length, Dr. Radby?
Yeah, I think that was a great explanation of this pretty rare disease and relatively new disease. So thanks for bringing it up again. Even though it is more common in women, my case also was in a man, and a young man also with a little bit of autoimmune serology that was positive as well. Did you have a response to MMF or a response to rituximab?
Yes, there was partial response to his proteinuria decreased by about 30%, but his creatinine also came down from 2 to around 2, from 2.9 or 2.8 came to 2. So it was a response, but he became diabetic with steroid. So we didn't want to continue with it, low dose prednisone, and he was not interested in it. And I was also worried about compliance in this case. So I thought rituximab would be a good option to keep him going. So I will see how he responds, or we can maintain that partial response. Yes, he did respond, I would say.
That's great. I in our case, we only had about 800 milligrams of proteinuria, and he was normal renal function, but we thought we'd just try an ACE for a little bit and see if that did okay. And he's actually gone down to like 200 milligrams of proteinuria, still with normal renal function. But it does worry me that there's an ongoing autoimmune disease that we may not be treating. And I kind of have a low threshold for going to start Rituxan, even though obviously there's really no data.
If you think about it, I mean, if you had a lupus membranous with 500 milligrams of protein, you probably wouldn't be aggressive on that either. So, I mean, I think this is kind of falls in the same category personally. I was thinking as you were saying, you know, to myself, what membranous, I mean, there's so many that the causes of membranous is so long now. What membranous would I not treat these days? You know, maybe if I knew it was a cancer, I might not treat it. I might treat the cancer first. If it was syphilis, I would treat the syphilis first. But, you know, now that we really understand all these antibodies, and they all seem to, I mean, you know, we don't have the data, but it's logical that they respond to, you know, rituximab, and it's really a pretty benign therapy, in my opinion. There aren't that many things we wouldn't, so I'm glad you treated him, and I'm glad you didn't give up because his creatinine was high, because I've seen the same kind of thing with, you know, PLA2R positive and PLA2R negative. So, come a long way.
Okay, so let's go to the real case today, which we are planning to discuss, and I'll ask Deepika to present that case. Deepika, please go ahead.
Dr. Reem, she had to drop the call. She's having issues too with her internet, so you may have to do this.
Sorry?
Deepika had issues with her computer, so she's not on the call.
Okay, so I will present that. This lady I saw about late 2022. She's a 40-year-old nurse from the northern part of Punjab, northern part of Pakistan, and was and she's a nurse by profession. So she presented to me with proteinuria. We'll go into that proteinuria, but most of her physical examination was totally unremarkable. Her blood pressure was under 30 over 82. She was non-smoker, did not consume any alcohol or any indigenous drugs. She's a vegetarian and was not on any medication. The only positive history was that her father had end-stage chronic kidney disease. She wasn't sure what was the cause of disease. He was a diabetic, so it was presumptive diagnosis of diabetic kidney disease requiring dialysis, and went on to have transplantation, and eventually died because of COVID infection. Can you give me the next slide, please? So when she presented to me, we chased some urine albumin creatinine ratio in 2017. It was 121 milligram per millimole. I don't have any other results there, but consistently her urine was positive for blood and protein, and I didn't do the microscopy, so I can't tell you she had CAST or not. But when I saw her 24-hour urine was 0.75 gram per day, and we put her on. I thought, okay, she has maybe IgA nephritis, and put her on renin-angiotensin blocking agents. But after about 4 or 5 months, after 6 months, her proteinuria actually worsened, became 97 milligram per millimole, and kidney size were normal, and we decided to do the kidney biopsy because I thought that she is on maximum doses of renin-angiotensin blocking agent. If we are presuming it is IgA nephritis, that would worry me. So we decided to do the biopsy, and let's go. Any question about the case?
No family history?
Move forward.
No family history?
A family history. Father was presumably diabetic, and was on dialysis, went on to develop had transplantation. So there was a family history of chronic kidney disease. Etiology not clear to me.
Do we know if the proteinuria is albuminuria or not?
When we did the urine albumin creatinine ratio, it was mostly albumin, I would presume.
Oh, I'm sorry, it's an albumin creatinine ratio. I apologize.
Okay, next slide, please. So here comes the poll. These are fun. These are all anonymous. You can tell me whatever you think I would know. Nobody will know who is answering who. So give your best shot. What is your what do you think it is? No takers? If your polls are working?
Yeah, I'm gonna give it a few more seconds. We have about
Okay.
16 people answered out of 24, so.
Okay, that's good.
Yeah.
Let's go. So majority patient went with IgA nephritis. Some went with thin basement membrane disease and other suggestions. What were those? If anybody want to comment, what was the other suggestion? What were they thinking? I'm very curious. What was the other suggestions? So Dr. Vadera, why don't you take over? You want to give us a differential diagnosis? Or what do you think? How you will approach?
So based on what you have shared with us, I went with IgA nephritis because patient has proteinuria, hematuria, all the other markers were negative. There could be a possibility of thin basement membrane disease, but unless we have the biopsy, it's difficult for me to differentiate between IG and thin basement membrane disease based on just the clinical picture which you have presented. I'm actually not familiar with elect-2 amyloidosis, so I'm curious to know what that is.
Okay, elect amyloidosis is described in 2008. Actually, the first case was described in Bangladesh, but it is found more in Punjab, both India and Pakistan, and also Hispanic and Egyptian. So this is an interstitial amyloidosis, and it presents as a hematuria and subnephrotic range proteinuria. Generally doesn't end up, it's a slowly progressive disease, generally doesn't end up to end-stage renal disease, but it's a cool diagnosis to think about this. And Dr. Behera says that could it be PGMIND? Why do you say, Dr. Behera? What was your thought? Hi, Suman.
Hi, everyone. No, I was thinking, since there is the picture that you presented, of course, that IgA nephritis is high on that differential. But then there are other things like, monoclonal, there could be monoclonal immunoglobulin deposition disease like MGIDD that could cause a similar kind of picture. If there is immunoglobulin like IgG, one or like if there's a light chain with kappa lambda like IgG1 or 2 with the similar picture of proliferative GN with a monoclonal IgG deposition. So that could be one of the things.
So you are thinking like proximal crystallopathy type of thing?
Is something like that, yes, because that can also be caused.
That's an interesting thought, but we could have seen in urine some Fanconi type of picture.
Right.
They generally present with that, and her urine was, other than blood and protein, there was nothing. So it's possible, yeah. So
I would say if I saw this patient and, oh, sorry, go ahead.
Sorry, go ahead.
I just would say that if I saw this patient in clinical practice, I would certainly think IgA nephritis is the, overwhelmingly most likely diagnosis. But there's a conference type mentality where you're always looking for more rare things, and you'd want to think of more rare things. What would not be on my differential is ALK2 amyloidosis, and by saying that, it probably means that this case will be ALK2 amyloidosis. But the reason I say that is because that's typically this, as you said, is a tubular interstitial pattern, and we don't expect as much albuminuria in those situations. And so my differential would be more IgA nephritis and possibly thin basement membrane disease, if that even really exists as a term anymore. And we're trying to move away from that diagnosis as a term, or possibly some sort of Alport syndrome. Knowing that she's female doesn't exclude that. I would add that to the differential as well.
Yeah, I agree. Any other thoughts?
And we're not even really supposed to be saying Alports anymore. We're really supposed to be describing it based on collagen chain involvement, etc.
Biogenic or something else, those kind of things. Any thoughts, Dr. Radby, Dr. Rubin, or anybody else?
I don't know. I'm kind of always in board review mode, so having spent the last 7 years or 6 years with the board review and always teaching people to pick up on the clues, right? So the minute I hear Punjab, my brain just goes immediately to ALK2, and I can't get out of it, even though Bill's absolutely right. That should be more of an interstitial pattern. And that's why I asked about the proteinuria until I realized it was albuminuria. So it's kind of hard for me to get out of that. I just okay, Punjab, ALK2, let's move on. But you're right. I think certainly IgA nephropathy is very, very common in that part of the world too. So we'll just have to, that's why we're doing biopsies, I guess.
That's right. I actually exactly thought IgA nephritis. I said, okay, we'll do this, and see what happens. When she started proteinuria started to get worse, there are other proteinuria levels which are rising. So I decided to do biopsy. And let's go to biopsy. What is Dr. Shubha Buru tells us what it is? Okay, take over, Dr. Buru.
Dr. Buller, did you want me to do
thank you, Dr. Ian. Yeah.
Dr.
So
Buller,
how do I control this?
Yeah, one moment.
I can keep asking for next slide, if that's okay.
No, I'm giving it to you. Just click on the screen and you should have access. Control. There you go.
Okay, what I received was two very good cores for light microscopy, about 18 glomeruli, and 2 of them were globally sclerosed. And as you can see, this is a single core with at least 3 glomeruli in this picture. It's not moving forward.
What stain is this?
That's a PAS.
Thank you.
Okay, this is a higher magnification of the same thing. What you can see in this magnification is very open ectatic capillary loops within the glomerulus, and you see some interstitial foam cells there.
Can you orientate, Shubha, what cells you are showing?
I don't know how to.
Oh, your pointer is working actually.
Can you see my pointer?
Yes.
Okay. And this is Jones, that is silver stain section, where you can see rigid ectatic capillary loops. And what I noticed was some of the endothelial cells looked a bit prominent, but I didn't really give too much notice to that subsequently. And I'll come back to that later. I don't know whether you can see in this magnification, the en-face sections show this lucent holes. So the rigid capillary loops, lucent holes. So I was thinking in terms of membranous, just by looking at light microscopy itself. So that's another section of Jones itself, where you see these lucent holes and en-face sections. The pictures are not great, I'm sorry about it, but probably did it in a hurry. So for immunofluorescence, I had a very good quality core with up to 10 glomeruli. And that's the albumin where you see the resorption droplets, protein resorption droplets in the tubules, which is lighting up with albumin, but albumin in the glomerulus itself is negative. IgG was positive with up to 2+ membrane capillary wall positivity. That's IgA. IgA was negative. IgM just showed focal up to trace positivity. The next pictures show C3 and C1q. C3 was positive with up to trace to 1+. C1q was totally negative. Kappa and lambda. You can clearly see that there is kappa restriction, definitely up to 3+ kappa, and lambda was barely, there is no fluorescence, but mild tinge of color I could see. Now going to electron microscopy, there was this capillary wall, epimembranous and intramembranous electron dense immune type deposits, not just within the capillary wall. I did see some of them in the mesangium as well. So that's again another capillary loop with nice membranous type deposits. So based on, okay, I'll leave this to Dr. Reen now.
What was your
Well,
pathological
I called it a membranous nephropathy with kappa light chain restriction.
Dr.
Ballor,
John, any comments?
Dr. Ballor, very quickly, you had hinted that there was some endothelial cell proliferation on the light. What did you mean by that? You didn't come back to that.
Dr. Witter. It's just that I felt that the endothelial cells a bit
Prominence?
up, just a bit endotheliosis, if I may say, nothing beyond that. I did not see any proliferative lesions in both of the cores. There is no mesangial there's mild mesangial expansion, but no hypercellularity endocapillary or extracapillary hypercellularity. I did not see any crescents. So nothing like that. I went quite deep in multiple levels. I did not see anything like that.
And it looks like on the EM, the fenestrated endothelial cell looks quite normal here, right?
Yeah.
And the foot processes are fairly diffusely or
effaced,
yeah, pretty
with
diffusely, which I'm surprised the proteinuria is not more with all those deposits in the diffuse effacement. That doesn't mean anything clinically to me, but I'm really surprised.
Dr. John, any comments on the biopsy?
Yeah.
A couple of things. That first slide of the PAS actually showed some what we call tubulointerstitial foam cells.
Yeah.
Which suggests that, I mean, in the old days, textbooks would say output, but it's really not. It's just any long-standing proteinuria. But, you know, it attests to the fact that there is some proteinuria that's been going on for a while. The second thing is that there's a membranous glomerulonephritis that's kappa, IgG kappa restricted. Could it be that a form fruit of that IgG kappa masked, or is just this true older person with the paraprotein? There's no subendothelial deposit, so somebody was asking whether there's proliferation. So the chance that there's proliferation also makes it quite unlikely. And the last thing I'll say, for which I'm not speaking as a pathologist, but just as somebody who has stared at biopsies for a long time, all this proteinuria, foot process effacement, and all that is beautiful in the research world, but it translates very poorly clinical. In minimal change and FSGS primary, there's diffuse foot process effacement. And I don't really know whether it's why it's there or why it's not, but it just correlates with proteinuria. In everything else, there's probably virtually absolutely no correlation between foot process effacement and proteinuria. You can see lots of effacement, no proteinuria, lots of proteinuria, little effacement, and so on and so forth. That's just my 2 cents worth.
No, definitely. Yeah, I'm not.
I don't know. I think Whittier has an opinion on that, I think.
Yeah. I didn't get Dr. Corbett, what did you say?
I said, Dr. Whittier, I thought had an opinion on that in membranous with foot process effacement. I don't know if he's gonna
I
step
can
up.
send out
I
a
know
article.
they wrote
No,
a paper
I
with my old friend David Simbaluk on podocytopathy and
Sure.
membranous. Oh, come on, forget it.
Sure. Well, the data is the data. You anecdotal's anecdotes, and the data.
Yeah, it's the interpretation of the data that's a problem, though.
Okay, so Dr. Bolo tells me that it's a membranous with Ig kappa. So what next? Her free light chains are unremarkable. So what do I do next? So I did ask myself a question, should SAP, next slide please. Should we do SAP on this patient? Yes or no, not sure. What do you guys think? Can you show the poll, Chef? Okay. So people said yes. That's very interesting. So you would like me to tell what SAP was? Okay. We did the SAP, and SAP was negative. And it was very kind of Dr. Larson to do it because his lab has actually is not, they are not doing due to reorganization there, but he was able to oblige me by that, and I'm very grateful for that. And Dr. John, do we do serum amyloid protein stain in our in Toronto Journal?
No, there's probably some other people who are doing it, and in the past, people used it more frequently to sort of confirm amyloid. But now, since people have resorted to mass spec, even those few places that are doing it don't. But there's some odds. Some people who are probably just doing it from a long time ago, but we don't do it.
And so people say yes, so we did it to please you guys, but it was negative. And why did I do it? Next slide. And I think somebody posted the paper. If you see that very paper where there were that was a masked membranous like glomerulopathy, in that very series, there were 13 patients where the Ig kappa was unmasked and the SAP was positive in 4 patients. So it would have helped me that I would have thought about autoimmune process, but unfortunately that was negative. So next, what do I do next? Can you show me next slide? Should I send hematology consult or bone marrow biopsy, malignancy workup, or I call Dr. Larson or Dr. Rodby or Dr. Whittier or Dr. Glasser? Who do I do? What do I do next? What's your suggestion? You can answer your by poll. Okay, you have the poll, Chef?
I'm just trying to launch it. It doesn't seem to want to launch.
Okay.
Yeah.
It's all blank. Okay.
It's not launching. It's internet problems.
Okay.
I apologize.
So what will you do, Dr. Whittier?
Sorry, I mean, if the SAP is negative, I would probably, knowing that there is a kappa light chain restriction, I would consider a bone marrow biopsy here.
Okay. Dr. Rubin?
I agree.
Okay. Dr. Corbett?
I never disagree with Dr. Whittier.
Sure.
No,
Dr. Mehta, you are on the call?
No, I couldn't
Hatash,
agree
you are on the
more.
call?
Pardon?
Hatash, my colleague, Hatash Mehta is on the call?
Yeah, I'm here. Yeah, I agree. I would do a bone marrow as well with the SAP negative.
I think it's a it's kind of an atypical pathology for a monoclonal, but so I think the SAP makes sense, even if the the patient's gender, age, or whatever, it doesn't fit that Larson's disease, as we call it. But so I think it's a solid thing to do the SAP first, but then you're clearly obligated to go ahead and do a bone marrow and look for a clone.
Okay, so let me tell you what I did. I didn't do the bone marrow. I did a CT scan of the chest for different reason, but I did something else. I actually asked for whichever pathologist already sent was. We asked for IgG subclassification. Okay, and I will tell you the reason. Can you show that slide, the results of? So what it was that it was IG1 was predominant, but there were also faint IG2 and IG4 was slightly present. So it had predominant of IgG1, but there was presence of IG3 and IG4. And I think that makes you think a little bit differently. Can you go forward, next slide? And if you see this paper, it's I think this was presented, this was published in 2017 in KI reports at, I think, volume 2. And this they reviewed, again, Dr. Larson was one of the authors. And his, you guys can read it, the details of this paper, but this paper is worth reading it because it gives you a direction what to do. So show me the next slide. And he gives a flow chart. If you have a membranous glomerulopathy with light chain and stain for PLA2R, and our patient PLA2 staining was negative, then do the IgG subclassification. If it is single IgG and PLA2R possibility, then you have a monoclonal gammopathy and investigate for underlying lymphoproliferative disease. In this series, 28% patients with this scenario were actually had lymphoproliferative disorder. If you have single IgG subclass plus PLA2R, then it is a so-called primary glomerulonephritis, PLA2R associated membranous glomerulonephritis. And if you have more than one IgG subclass, which this patient has, PLA2R is negative, it is unlikely to be monoclonal gammopathy of the renal significance. Most likely, it's a idiopathic membranous glomerulonephritis. And if it has more than one and PLA2R positive, then it's a PLA2R associated monoclonal gammopathy. So that's it. I was thinking. Before I went for hematology council, we actually did that. I did ask the hematologist. This is my first or second case dealing with this kind of disease. I did ask a hematologist to see, and she did a just CT scan. There were some fibroadenomas, both breasts, so which was confirmed on mammogram, and now she's having ultrasound. Radiologist is pretty sure that it will be probably fibroadenomas, but I just want to make sure that that is what it is. So we have decided to defer the bone marrow at present time. We are treating as idiopathic membranous glomerulonephritis. I will continue to maximize the renin-angiotensin blocking agent if it doesn't, and I will follow her free light chains closely. And if they get abnormal, we do the bone marrow. But at this time, I personally don't think bone marrow is indicated, but I'm open to suggestions. That's why I'm presenting this case.
How old is
41.
How old?
41.
41. Okay.
41.
And a woman.
No, and a woman.
Yeah.
Tough case, right?
So, yeah.
Sorry, Dr. Reen, question. Sorry, I missed the ending. The fibroadenomas, on the mammogram, there was no, not like those weren't anything significant. You said they were just.
Well, we are investigating further.
You are investigating.
For sure. I'm not going to go on. She has a bulky breast, so I think we are obligated to investigate her further. We are pursuing, she's having a designated ultrasound by our screening program. we will probably ask her to see a surgeon, but clinical impression, radiological impression is most likely fibroadenoma. But it has been clearly ruled out. Answer is no. But I'd be very surprised with no family history of any breast cancer or any other cancer. She will have bilateral, but you never know.
Yeah, at that young age and bilateral, so something genetic, but if there's nothing there.
I find these always confusing though, because you do have capital light chain restriction nonetheless. You never quite know how that all plays into it, but the assumption here, from at least my perspective, is still that there is some restriction, which makes you wonder, why wouldn't there be both kappa and lambda if this, if this were not some sort of an isolated clone, if you will. I never quite know how to deal with these. You could probably go either way with it. You said the kappa lambda ratio was it done, or I don't recall the.
It was done. It was normal.
Yeah. Yeah, and that's pretty sensitive actually, and fairly specific as well. So, yeah, I don't know. I find these very interesting and very confusing at the same time.
She has to be followed very closely. If her proteinuria goes up, I may consider bone marrow. But she has seen a rheumatologist. There are no lymph node, nothing, just these are incidental findings and CT scan we were doing. I can do bone marrow, but
well, even in bone, some of these people, even with bone marrow, we've all seen these cases where they don't have really much there, and then you're still left with, is this still some paraprotein associated form of renal disease? Because then the issue is, do you treat it as that? And I've had patients we've sent to hematology whose bone marrows are negative, and we end up treating them as if they had a paraprotein associated form of renal disease, and they actually get better sometimes. So you kind of wonder if we're just not sensitive, if the bone marrow's not sensitive enough either to pick some of these things up.
No, I think that's
I actually
that's a good
rituximab was back of my mind anyway, and I haven't ruled that out as yet. Dr. Ravi, you were saying something?
Yeah, I just saw that. I mean, that's what Chris Larson is. That's the kind of point he's made. I think the point he's trying to make is that this is it's a certain phenotype, young woman, kind of autoimmune looking, and then has this. It is not a paraprotein, and I don't. Does that mean that if you have this, that you don't do a paraprotein, workup and a bone marrow? I don't know. But I think he's trying to say this is a well-described lesion that is not a monoclonal gammopathy of renal significance.
Actually, it was interesting. Dr. Larson did comment when we sent him the material for stain, and he had the biopsy report in front of him. He was actually did email me. Doesn't look like it is MGRS. That was his comments. It came from the expert also. Yeah. But I had made up my mind even before his comment. I think I will treat it as a idiopathic, and my choices are renin-angiotensin blocking and possible considering rituximab once I ruled out this breast lesion, what it is.
I mean, whatever.
Ruben, do you have any comment?
Yeah, I do. Interestingly, Dr. Sethi, at a recent GlomCon presentation on membranous, made the point that the IgG isotypes are not that cost effective. I tried to pin him down on the subject. He was quite evasive, but that's a point that he's made, and I'm still waiting for him to answer my email along those lines. The other question I have is, why are you reluctant to do a bone marrow with the understanding that it could be negative? And what Dr. Robert Kyle taught me many, many years ago is that many of these processes are focal, and therefore you can miss it on a bone marrow examination. But somebody has also brought up the issue of a PET study. So personally, I would have pursued the effort to try to identify the presence or absence of a clone, with the understanding that in many, many instances, it's an exercise in futility. But I was just wondering.
I take your point, but my thinking was that one of the added, if you see the biopsy, if they have proliferative changes on biopsy, then they are a high-risk patient. I would have definitely considered bone marrow at that time, and even further investigation to make sure that this patient doesn't have underlying malignancy or lymphoproliferative disorder. But she doesn't have any proliferation, so it's a low-risk lesion as per biopsy. So that was my thinking, but I'm open to suggestion. I haven't ruled out completely, but when I was reviewing that, I knew this paper very well, so my mind was already biased. But talking to your IG1, it may not be as reliable. I think I have completely read the paper. I think I can find out a recent paper came about maybe a couple of weeks ago, actually describing that very sentiments what you are saying, Dr. Rubin, and I probably will find the paper and email it.
Yeah, supposedly
that is what that paper says. IG1 that may not be as sensitive as we think.
Yeah, what Dr. Sethi also mentioned is that there was a recent meeting at the Mayo where they came to some sort of a meeting of the minds, and there will be a publication or two relating to that and addressing the issue of isotypic determination. So stay tuned.
Yeah,
Dr. Rubin, when you were discussing that, and I missed that GlomCon, is it that it's not cost effective to do it on every single biopsy, but then when you have something that's a little bit more suspicious, possibly you should? Or was it that it really isn't helpful even when there's something suspicious? Like, what was the take-home message for subtyping?
Very obscure, unfortunately.
Okay.
And that's what I pursued with an email to Dr. Sethi, but he had to answer.
I think,
thank you.
Mario's point says it may be an exercise in futility. On the other hand, bone marrow is not fun, but it's less risky than a renal biopsy.
Well, the other thing, you've got a young person here, and although the odds are that it's not likely you have a paraproteinemia in a 40-some-year-old, you did do a biopsy and you did find evidence of what looks like restriction. And the question is, are you willing to bet the bank on not doing a bone marrow because you think there are enough other features that suggest it's not a bone marrow related disorder? I mean, we're talking about one patient here who's relatively young. Who are you willing to miss the opportunity to diagnose something that you might want to treat?
Yeah, I presented this case to be controversial and get opinion from people, but I'm still keeping open bone marrow. And it looks like consensus is telling me I should do bone marrow, and I will suggest that.
And I like the fact Mario brings up Dr. Kyle again. I don't know how many people remember him, but for years his publications almost every year were the Mayo Clinic's experience with amyloid and myeloma. I mean, it was like the best reading ever. And I remember well the same thing, is that if the iliac crest is negative, do a sternal biopsy because it is patchy.
Okay, so just to go back to the slide, Chef. So next slide. I just want to finish with this thought. Years ago, when nephrology was maybe 20 years ago, we had clinical history. Pathologists look from light microscopy, immunofluorescent, electron microscopy, and then we'll have a diagnosis. I think times have changed now. Next slide. Now we have clinical history, physical examination, but new labs such as PLA2R antibodies, thrombosporin antibodies, and then we have various stains on microscopy. And then we have paraffin IF, which we discussed today. Electron microscopy came up, mass spectrometry came up, and where we are finding all sorts of antigen and membranous, and we can distinguish between our in our amyloid panels, Genetic studies have come up. I'm a big fan of genetic study, and stay tuned for AI and digital pathology. So I think I always feel that nephrology, glomerulonephritis is a team where patient is involved. It gives the history, physical examination, and you do lab on that. Nephrologist who teases out what investigation to do further, and then pathologist. So we should work as a team. I find it very difficult most of the time for a pathologist gets, okay, rule out IgA nephritis, no other history. So I find we should work as a team. At least our institution needs to look very closely into this, that we should work in collaboration with all our team. I'm also, this is for Dr. John. I think we should, time has come that we look into these new antigen, which we have to send to Mayo Clinic. Like last month I presented NEL1, I had to send it to Mayo Clinic, and exotosin 1,2 also to Mayo Clinic. So that is time consuming, expensive. So I think you as a university academic center, I think you should start looking into this. Can we perform these antigen locally with the, and community people have access to those things. So those are my thoughts. Any other comments on that? I'm not keeping up with the chats.
So Dr.
Yeah, whosoever else had was negative in this chat.
I agree with you fully. Now, as a corollary to this outstanding presentation, I want to ask the group, and this is an unrelated question, but I just learned about this. I thought I'd share it. Some people may know the answer. Who was the classic music composer that died as a result of complications from IgA vasculitis? There was no Cytoxan, there was no rituximab, and Dr. Whittier has the answer.
Mozart.
And Amadeus Mozart. Unbelievable, Bill. Thank you.
We both study music and history together.
Well, I thought Dr. Corbett will have that answer. I have seen him video with the guitar playing some music with Dr. Dylan, Hamul Dylan.
Yeah, Bill came to the rescue again. Thank God.
I just like Neil Young and his comment on biopsies when he's saying a needle and the damage done.
Actually, there was a post today on the internet about the premise, what that song was about.
All right. Thank you, everybody.
What I want to know is, how do we know that it was crescentic IgA, Mario?
I have no idea. I have asked myself the same question.
It's like, well, never mind. There's something else that'll come up around Christmas time that I always bring up. But yeah, I find it interesting. I'm thinking they weren't doing immunofluorescence then, so.
No idea.
Oh my God.
Okay, thank you, ladies and gentlemen. Thank you, Dr. Arby, Dr. Whittier, Dr. Rubin. Thank you very much. And Dr. Corbett, of course.
Thanks so much.
Thanks, everybody.
Thank you, Dr. John.
Thank you. Thank you.
Thank you.